Cable. I am the CEO of CModel Data. CModel is a decision intelligence company that relocated here to Birmingham about a year ago from California. What we do is we help business leaders to navigate the growth journey through business decisions. One of the key things, though, is that business decisions they don't just happen in the context of a business trying to grow, but they happen throughout our healthcare system as well. So we wanted to start to dive into what does it look like when you start thinking about the implication of decisions and what the future of health might look like. So what we've done is we've got a fantastic lineup for you today. One of the things we know to be true in today's healthcare system is that there are a myriad of challenges. But what there also is a myriad of opportunities. And that's the thing that we want to focus on today, is what do the opportunities actually look like? And so in the midst of these challenges, I just said this, there are opportunities. So anyway, we can navigate all the complexities of this and really start to focus on shaping healthy communities. So for today, we want to discover a couple of things. One is, how can we use data and analysis and the measurement of performance to help make smarter decisions? And the reason why we want to do that is because we want to talk about how to potentially improve outcomes. These can be patient outcomes, these can be efficiency markers within an organization. We want to talk about how we can start to leverage our collective thought towards those things. And in order to guide that, I've brought together two exceptional leaders. One is Dr. Marie-Carmelle Elie. She is the Endowed Professor and the Chair of the Department of Emergency Medicine at UAB, and Mr. Jose Dueñas, who's the CEO of SmartTracker. And we also have a special guest who I'll introduce to you later. So let me tell you a little bit about Dr. Elie before they come on the stage. So Dr. Elie is a true trailblazer. Not only is she an endowed professor and the chair of the Department of Medicine, Emergency Medicine at UAD, right here in Birmingham, her career has been dedicated to pushing the boundaries of emergency medicine, critical care, and palliative care. She's a triple board certified physician, a clinical trialist, a former research director, and a champion for improving patient care through innovation and collaboration, which is why she was my choice to be here today for this conversation. And if that wasn't enough, she was also elected to the National Academy of Medicine in 2022, and that is something to celebrate. So would you guys celebrate Dr. Elie? Our other panelist today is Jose Dueñas. He's a force to be reckoned with in the world of public health management technology. So he's the CEO of SmartTracker. He's dedicated his entire career to developing and implementing solutions that empower healthcare organizations, specifically data-driven decisions. So his passion for public health specifically, stems from his childhood experiences growing up in South Florida. He saw firsthand the vital role that community health services can play in ensuring the well-being of vulnerable populations. This experience ignited a fire in him to make a difference, and he's been doing that ever since. He led the redesign of the NetSmart Public Health EHR system for the state of Tennessee. He spearheaded a nationwide launch of an electronic initial case report with the CDC and the state of Michigan. He's also consistently pushed the boundaries of what's possible in healthcare technology. And with this tool, SmartTracker, that the company he's the CEO of today, he's helping organizations across the country to take control of the power of data to improve patient outcomes and streamline operations. So we are grateful for the two of you today and joining us, and I look forward to the conversation. Let's give it up for our panelists. So let me tell you, as they come up, I'll tell you more about what else we'll do today. So after we have the panel conversation, what we're going to do is go through what I call a future scenario. We're going to take a look at, there's some strips of data on your table and you can share them amongst one another. And we're going to go through an exercise where we create a shared vision of, for a future, I call it getting on a spaceship. We're going to get on a spaceship, we're going to leave Alabama behind and think about what happens if we built a new Alabama healthcare system. What would that look like? What are some of the ideas in this room that can transform what would happen in the future? So that's another one of the exercises. We will talk about it. We will also have lunch, so don't leave before lunch is served. And we're just going to sort of collaborate and network together to think about what the future might look like and how the decisions we make today can impact that particular future. So thank you again. Yay, thank you so much. I just learned today. These are two people who haven't spent a lot of time here in the Innovation Depot. But this kind of thing is what is actually like happening in spaces like this, where we have an opportunity to think not just about what we're doing day to day in our own silos, but how we can come together to start talking about these issues or opportunities in order to build a future, specifically here in Alabama. So without further ado, let me get started here. So Dr. Elie, I'm going to start with you.
Sure.
I'd love to know more about your journey and what inspired your career in emergency medicine and leadership within the academic healthcare space.
Sure. So thank you for that question. It's my favorite question. Many of you have probably been introduced to emergency medicine from perhaps, I might be dating myself, the show ER, or seeing residents or physicians sort of depicted on television with patients that are coming in through the ambulance system into the hospital. Emergency medicine, though, is actually one of the youngest specialties. There are a total of 29 specialties, and it was the second to last to be created. So it's actually one of the youngest specialties in the House of Medicine to have been created, and it was created about 45 years ago. And at that time, there weren't really emergency physicians. Generally, there were just physicians who had an interest in taking care of acute care patients, largely because many physicians needed to stay in their office and couldn't drive to the hospital to see their patients when they were having an emergency. And so they needed someone to be on call in the hospital in the event their patient showed up. So over time, as physicians that were in their offices spent more time in their offices and less time in the hospital, they became more reliant on physicians being in the hospital in order to take care of these individuals. And that was the birth of emergency medicine. The reason why I chose emergency medicine is largely because of what our country has done to sort of establish the system of acute care. Emergency medicine is what we call the safety net. So when patients come in, I actually am able to see a patient of any age, a patient that has any medical condition, with any complaint. And so this specialty really allows me to use all of the skills that I've acquired over the course of my career for every patient. And so my first hour, I may spend some time working with someone that has a foreign body in their eye. The second, I could be working with a patient that's come in because she's pregnant, a little concerned about the movements of her fetus. My next hour, I might be in a room with a trauma patient that's been in a horrible accident. And so every hour, I get to wear different hats, and it gives me that opportunity to sort of exercise all of the different disciplines. And it is exciting that way, but I think what truly inspired me to work in this space is that I don't need to necessarily check my patients or triage them and decide who I get to take care of. Anyone can come in the door and I'll take care of you. I won't check, I won't say, well, you're too young, you're too old, you've got this kind of condition, there are conditions above the waist, below the waist, and I'll see anyone. And the beauty of that is I can always meet patients where they are, regardless of where they are, and that for me is a privilege, and that's why I chose emergency medicine.
That's awesome, thank you. I love the idea of, and I want us to keep this in mind for the future scenario. I can meet people where they are, because in the future, that should also, or could, not should, I'm not dictating anything, that could also be a consideration for what healthcare looks like in the future. That there is this openness, not necessarily considerations that silo, more things that silo us. Okay, so thank you so much. So Jose, what led you to the creation of SmartTracker, and how does it address current healthcare challenges? And think about those that you've already studied here in Alabama.
Yeah, so thank you for having me. Thank you everyone for being here. So my journey to building SmartTracker is actually very personal. As a first-generation American growing up in Miami-Dade County in a migrant camp, I benefited from the public health system, and I'm truly grateful for it, but I've also had experienced the challenges in it. Everything from vaccines to physicals to dental care to living in a domestic abuse center with my mom and brothers. I've gone through the system. I know the challenges. Fast forward, working in reporting and data, I knew the challenges were there for health departments and any health and human services agencies to collect the data, extract the data, analyze it, so that they can make proper decisions, better outcomes for patients, and what's so crucial is preventative care. And I think that's the big opportunity, especially here in Alabama, is that with this new data collection opportunity, we're able to really launch interventions that can help prevention, help folks know the knowledge or the power of what programs are out there to help them. Better eating, better dietary education to the community, so it's a stronger, more resilient workforce here, and I think that's a huge opportunity that we all have.
I like the idea of a stronger, more resilient workforce. And one of on the tables, there's some data points, and there is a data point, I'm not sure if you have it handy, specifically around the number. Go ahead. What were you going to say? Yeah, no, it was specifically around the number of people with chronic illness in Alabama. These things that are, not all of these chronic illnesses are, they can be prevented, right? So there are things that we can do, lifestyle changes to adjust. So again, in thinking about our future, we want to consider some of those elements. Do you have that data?
Yeah, so off the top of my head, I believe it's like 63% of deaths are caused by chronic diseases, right? And that is costing, I believe it's $31 billion and $14 billion in lost productivity. So it's affecting us when folks have, emergency room visits for diabetes or heart attacks, right? We lose productivity, we lose folks in the workforce. Everything is interrupted, not only for that person, but their family.
Absolutely. Thank you. So, Dr. Elie, how can healthcare organizations like yours start to think differently about data and analytics to not only improve patient care, but also enhance operational efficiency?
Another great question. So many of you may have seen the crowded hospitals during COVID, how there were structures in the hallway, and it was very difficult for folks to even get into the hospital, or if they were there, perhaps in the emergency department, would be waiting for several hours, maybe even several days to get in room in the hospital. This turns out to be a universal theme, and it is a crisis that's nationwide. Now, how did we get here? So many people will say it's COVID, but it's not COVID, because if you go down the road right now to any emergency department, there is some degree of crowdedness in all hospitals. And so what happened? Did our population double in size? Why are our hospitals so crowded right now? And what could we have done 10 years ago, 15 years ago, to actually anticipate that this was going to happen? So here's the thing. Medicine, technology, a number of advancements that we've been making along the way have really gotten us to a place where we do have much better healthcare. Our life expectancy is increasing. every 10 years, right? And so year after year, we're getting better at taking care of patients and giving folks, or just giving people within the United States better health care so that they can have more longevity. But here's the thing. There are people that are surviving right now that would have never survived 15 years ago without some of the technology and advances that we have. And so we didn't anticipate that we would have a growth in a population of patients that have complex, medical conditions. And because of that, we've increased the complexity of patients that are coming into our hospital system, but we also are dealing with an increasing population. So over the past 15 to 20 years, the proportion of our geriatric population has doubled. The proportion of geriatricians and primary care physicians has plateaued. So in about 10 to 15 years, when people like myself, I don't know, maybe not retiring then, but many people will be moving into those geriatric years, there probably won't be enough physicians. And we can anticipate that now. And today, there aren't enough beds. And so the question is what can we start thinking about? So I think the first thing is to really use data to take a look at some of the trends. How are people aging? What types of healthcare are they accessing? And how are people aging well, right? And what does that look like? And what can we be modeling today that'll give us the opportunity for people to age well in the future and not necessarily spend their last weeks of their lives in the hospital, because that, in fact, is the case. About well over 60% of the elderly population will spend their last 4 weeks of their lives, or some proportion of that, in a hospital bed. And most people don't want that. However, most people do envision living well, aging well, and I think that there are opportunities for us to take a look at how we can do that outside of the traditional four walls that exist in our hospitals. And so I do think that taking a look at some of that data, the trends in how we're living, the trends in how we're aging, to help us to define what the future is going to look like.
I like that. Thank you so much. One thing that'd be good when we get to the future scenario is thinking about Alabama specifically. You can even think to Birmingham. What are some of those lifestyle elements? What are some of those things that indicate to us right here whether or not we're living well, and what it might look like here? So just keep those thoughts and data points in mind as we continue to navigate this. So Jose, how can technology, particularly tools like yours, be leveraged to really improve data collection? That's where we want to focus here, specifically in healthcare settings. Can you provide specific examples so that we can think about how data collection is impacted here? And before you go, I'll add that we know that data collection is work, right? So when we think about a metric, just as something for you guys to think about. You think about a metric has to come from a combination of data points that end up turning into that metric. Well, to collect that data, there's work to be done because you need processes and people in order to effectively do that. So in thinking about your specific example, I just wanted to make sure that was on the table as well.
Yeah.
Okay.
Thank you. So as in Alabama and elsewhere in the U.S., health agencies normally deal with collecting data in using various tools, right? So think of Excel. They could have an electronic health record system. They could be using SurveyMonkey. They could use another for appointment reminders. So SmartTracker eliminates that by being one platform that can handle not just this electronic engagement with patients, but also with hospital systems, also with referring to other community partners. On top of that, SmartTracker is the only system that I know of that allows the Health and Human Services to collect data on public health services. So think of STD, HIV, family planning, maternal, behavioral health, counseling, crisis intervention, suicide, and environmental health. So what's in the wastewater? What outbreaks are we seeing? We've never had a system that collected these different points of data, right? And so some examples that we have is, one is disease surveillance. So we worked with the city of Kansas City. There was an outbreak of Ebola, and in 14 days, we were able to launch our system to start tracking electronically, communicating with patients for them to fill out their screening forms, their symptom tracking, and giving them a better containment of a possible outbreak or situation that could have occurred. Another example is immunizations. When the Mpox vaccine was approved in Missouri, Kansas City, and St. Louis with us, we launched it within 2 days to begin folks to start scheduling. So this is scheduling themselves electronically. So there's no phone calls, no having to come into the health department. You are able to electronically schedule yourself on your phone, tablet, computer, and they were able to launch this mass vaccination event within days. In Texas, we launched with a certified behavioral health center, a program for outreach to high-risk children, and within 14 days. And the goal is now, especially with our partnership with CModel, is all these different events, these different data collections that is occurring, we now can take this data and do advanced analytics to help agencies, cities really be more efficient, reduce costs, and launch these interventions in real time and save lives.
Thank you so much. So, Dr. Elie, given the increasing emphasis on value-based care and regulatory compliance, how can healthcare leaders use performance measurement to drive more strategic decision-making to make sure that there's long-term sustainability? What are some of the key metrics?
So I'm in emergency medicine, so unfortunately, value-based care does not necessarily exist in our space, but it does exist around us. And you know, we talked a little bit about this earlier, looking at chronic disease. So the management of chronic disease actually can often prevent folks that were having to go to the emergency department. Well-managed hypertension and nutritional counseling could prevent someone from having a diabetic emergency or a hypertensive emergency that would lead to a stroke or other emergency that would require admission to the hospital, and also other complications that increases cost to the healthcare system, but most definitely increases the comorbidity and complications that an individual will actually incur over time to their health. And so there's a personal cost, right? A health cost to the individual for not having that managed properly. Maternal health, another component where tracking women that are pregnant and ensuring that their blood pressure is well controlled. We're looking at things like glucose control and ensuring that they have a healthy pregnancy, not only for themselves, but for that fetus that is ultimately born, and reducing the death associated with women that are pregnant in this country and in the state of Alabama. These are all metrics that have been that actually exist today to help us to understand how best to take care of our populations. So improving high blood pressure, improving diabetes, reducing the maternal deaths associated with pregnancy are these sorts of things that a lot of value-based care organizations are focusing on. In my space, one of the things that we're looking at doing is we actually are going to start ordering a test called a hemoglobin A1C. You probably have seen there's a lot of commercials now with a lot of singing, but I think A1C is something that folks probably are familiar with. But A1C basically helps you to track your diabetes control. And it's not necessarily something that we ever measure in the emergency department, but by leveraging that one tool in the emergency department, we can identify people before they even know that they have diabetes, who are pre-diabetic, and refer them to a clinic for that nutritional counseling or medication that will help to control their glucose so that they don't end up having diabetes later on. And that's often the way that this usually sneaks up on folks. They have a condition for months or perhaps years that becomes chronically worse without an intervention. So that is an example of something, one intervention that can be done in our healthcare space as part of value-based care that ultimately helps population health improve.
This is awesome. I want to ask a little bit of a follow-up, not on script, because I want to think about how these decisions get made to start leveraging technology in this way. Tell us a little bit about how that decision happens? And is there any community input in that decision?
So, excellent question. I will tell you, the primary driver of how these decisions are being made are often by the financial institutions that are paying for the healthcare, right? So we're talking about insurance companies. Insurance companies are typically the ones that are driving the value-based care. But in the past 20 years, it's not just been the insurance companies. The employers are starting to drive this too. And employers want employees that are going to have longevity, that are going to be well, that are going to be healthy. So there was an organization established about 20 years ago called the Leapfrog Group. And what they would do is they would ask for feedback on some of the quality metrics at the various institutions, so it would inform them who they would partner with and who they would basically contract with in order to provide healthcare to their employees. So we're talking about large industries here, like Boeing and IBM, that were basically bought into this system to basically inform them where are my employees going to get the best healthcare. So large employers are one. Definitely the insurance companies, because insurance companies understand that if you're getting better healthcare and preventive healthcare, and you're not suffering complications that land you in the hospital, that create more comorbidities, that actually it's less expensive. And so they're the other drivers. So those are usually the folks that are driving a lot of these decisions. And ultimately, it is the patient who really should be involved in making these decisions. Unfortunately, I think that as a healthcare industry, we do a poor job of engaging patients themselves. They're the consumer. And it is very rare for us to walk up to the consumer and say, what are you looking for in a healthcare plan? And we know what we would like, but that doesn't necessarily align with what is created as part of a metric. And we're doing better. We're getting there, but we certainly have a lot of room to grow in that space where we're really engaging our patients.
This is great. In the future scenario, it doesn't have to be that way, right? So when we think about what does the future look like, do we want a future, these become the questions we ask when we do the exercise, do we want a future where the patient is less involved in how the system is structured, or do we want to make an adjustment? So far, helpful? Are we learning some things? Is this informational for you all? Just getting a tone check in the space? Awesome. I'm gonna keep going. So on this same topic, but kind of flipping it to, now you're an organization and you need to implement technology. What are some of the barriers? What are some of the things to get in the way? We've got about 5 minutes left on this segment, just FYI.
So for many health and human services agencies, it's cost. The big systems will charge for text messaging, e-forms, telehealth. So cost is a huge barrier. So what do? They use Excel. In today's age, think of this, the city of St. Louis came to us, they're still using paper. We're their first electronic system, right? We were able to take Kansas City, and instead of them manually entering 200,000 records of vaccines that they had administered, we were able to import it into our system and upload it within 5 minutes, saving them so much manual errors as well and cost. So the big barrier for a lot of these smaller agencies, even big city health departments, is the cost of having the technology, then having to hire IT to support it, right? A lot of nurses then have to learn how to be report writers in IT. And that's what SmartTracker is trying to eliminate, this barrier, so that we can get the data.
So this is my favorite question, and I'm going to ask it to both of you. The first one is, so if we look forward, right, what are some of the emerging trends and technologies that you believe will have the greatest potential to transform healthcare? And not just the delivery of it, but actual impact on patient outcomes.
So, I teach a lot in a lot of communication amongst physicians, and most people would assume that in medical school at some point there's been a formal course on how do you speak to the patient, how do you address this issue with the patient. It turns out there is no such thing. Nobody's ever watching you, no one's coaching you, it doesn't happen. If you're in the right environment, you'll find an attendee or a faculty member that will coach or perhaps give you feedback. But the vast majority of the time when you're having a conversation with your patient, there's nobody watching you to make sure that you're actively listening and that you collected all the information that you should, and that perhaps you're being empathetic and using some of your emotional intelligence as part of that conversation. The reason why I'm bringing all of this up is because there are a lot of distractions in healthcare. And so every time in the emergency department, I'll use this as an example, a physician walks into a patient's room, there are any number of distractions. The beeper, the phone, the beeping of the monitor, and of course there is the computer where you need to get to and document. And on average, providers, nurses, and physicians are spending more time documenting than they are listening to their patient. And you can just imagine how much information gets lost in translation as you're having that communication. So I think one of the biggest trends that I'm noticing now, that I think is going to absolutely transform medicine, if we're able to just really right-size this for the healthcare industry, is allowing AI to listen in on the conversation. So there's that distraction is pushed away, and now it's just you talking to your patient. You're not writing notes, you're not back there typing something into the computer, but rather AI is like pulling down all that information and all that data. So when you're walking out of the room, your notes mostly completed, all of the problems that your patient told you about are listed, you're not forgetting anything, and you're able to use that information to manage your patient in a smarter way. And not necessarily being tasked or multitasked to do multiple things at the same time. So I think that is a really exciting modality that's being rolled out. I'm hoping to bring that to UAB in the next couple of years. But I think that would absolutely transform healthcare. The opportunity for a physician and a patient, or a nurse and a patient, to just have that unobstructed, unadulterated conversation and communication, I think would really transform the way that we take care of our patients.
I love that. That's a great example. It's a very great, very specific AI use case, which is part of what a lot of people struggle with when we think about future tech, is there aren't good, clear use cases, business cases, and that is one. So thank you for that. And then
I agree. I'm very, very excited about the predictive analysis that AI will be able to do. Imagine our system collecting different symptoms that are happening, outbreaks. On top of that, we may have some wastewater testing and know that, hey, there's going to be an outbreak of COVID next quarter, and we can alert the emergency rooms, the media, to help prevent some of these cases. And so AI and will help with this predictive measures that can be taken. And then on the patient care side, I'm really excited about AI, and while we're all sleeping, AI is analyzing a patient's record. It could be their labs, it could be how they answered a screening question, right? They are their high blood pressure, they're saying they're not getting good sleep, etc. And then AI will alert clinical staff that this patient potentially may have this condition and they need to be tested for it. So when they walk in the door, they're walking in with already alerts on how to help with that prevention of care.
And just, I'll give you guys a little bit of a place to put this information around artificial intelligence. So first, being clear that there are multiple types of artificial intelligence. One being machine learning. So you have supervised machine learning, which has existed a long, long time. Now you have unsupervised machine learning, and generative AI is an offset of that. So this is the ChatGPTs of the world. And then you also have things like decision intelligence, where now you take causal inference, you combine artificial intelligence and data and analytics and build more predictive models, which is what CModel does. So those things make up some of the landscape of artificial intelligence. So when you hear about these different parts, we're not just talking about like the ChatGPTs, OpenAI tools of the world, right? There are multiple types of technologies that go into this bunch. So I look forward to seeing some of these future techs in place. So before we do the Q&A part of this, thank you guys so much. Stay here though, because we're going to do Q&A. But before we do, I brought a special guest, and it's a business spotlight that I'm going to bring up. All of this is all input into our future scenario that we're going to do, right? And so I want to bring up Ms. Addie Ray, come on up, and we're going to have a brief little intro and conversation. Just so you guys know, I'm just going to bring this chair. So I have been meeting CEOs all over the state of Alabama. That's been my mission and my goal since I got here. And I've talked to hundreds. And one day, I logged into my Zoom call to be greeted by Ms. Addie Ray. Addie, she likes to be called Addie. So Addie and I sat, we had one chat, and I just enjoyed the conversation so much that I thought, let's talk again. And we talked again, and we've been talking ever since. And I thought that it was important that we share her story, at least some small part of it, and then I'd hope that each of you will engage with her while you're here. Just so that when we think about healthcare, we have full consideration for the landscape. Full consideration of the people. And I do believe that a rising tide will float all the boats. And so we often think about things in, siloed ways when we think about healthcare, right? We think about this group and that group. But I want to make sure when we say all groups, we're thinking about all groups of people. And so I'm so appreciative of you being here. First, would you tell us a little bit about you and your company, Access for All?
Yes. So to give you a background, I think it should be noted that I'm visiting from just south of here, Mobile, Alabama. I have my business, Access for All LLC. I focus on Title II and Title III ADA compliance and disability inclusion consulting. I do a lot of events like this where I speak on, my experiences. Sometimes for my clients, they need a, shall we say, go-to presentation, and when they need that, I do a presentation on what the ADA is and why it is beneficial to both businesses and society. Technically, I've been in business a little less than 8 years. It'll be 8 years in August, but I've been dealing with the disability sector my entire life. I was born premature. When I was born in August of '93, they told my mom, you may want to see her now because she may not make it through the day. That's how serious the situation was. Eventually I did survive, obviously, but not without a brain bleed, which brought on the condition known as cerebral palsy, often abbreviated as CP. This can affect patients in a variety of ways, including verbal issues, learning issues, issues with walking, mobility, which is my particular area, but it is a very wide disability.
Thank you so much. So tell me a little bit about how you see the intersection of healthcare, entrepreneurship, and really advocating for accessibility, just making sure that everyone has the opportunity to thrive.
So as far as the intersection of disability and entrepreneurship, which is what I focus a lot on in my work, one thing I think we should note is that entrepreneurship is booming in the business world right now, especially people with disabilities. To share a personal story of mine, I tried to go the conventional employment route. I worked with my local vocational rehab office, abbreviated down there as ADRS, Birmingham Department of Rehabilitation Services, and my Goodwill Easter Seals office for more than 2 years, putting in applications. And we were upfront with the fact that I have a disability because it is a mobility and visible disability. You can't miss it. It's right in your face, so why hide it, right? Never got even the first interview request, and so eventually my counselors and I, we all sat around a table and we said, this isn't working. So we decided to go the entrepreneurship route. It took me about a year and a half to get all the legal paperwork and what have you in order, because you do not want to go in business without having that in order. But yes, I've been glad to get it in order.
Thank you so much. So my intent here is to just ensure, as we think about the future and we think about the future of healthcare, we think about the future of pretty much anything and how healthcare can intersect with entrepreneurship, how it intersects with the decisions that we make, like we talked about earlier, in how we decide what healthcare looks like for different people, that we also consider what Addie Ray's scenario is, and even her business in itself, what it is, which is going out and educating people on how to apply the ADA laws. How do you make your business more accessible for us? And so, Addie, thank you so much for being here. She'll be at this table. I would love for you guys to engage and get to know her, get to understand what some of her needs and challenges are. And she's also available as we do the Q&A. If you have questions specifically for her, please do ask them. So I'm going to open the floor now for questions that you might have of the panel, including Addie. And we'll do that for just a few minutes before we jump into our future scenario. Okay, so if you would, Addie, if you would maybe just move off a little bit to the side there, that'd be helpful. Thank you so much. Would you guys give everybody a round of applause? Do we have any questions? Yes, ma'am.
Hi, my name is Brittany Jenkins with Jenkins Public Health Consulting. Chronic disease is costing Alabama $44.4 billion annually, and medical costs and lost productivity, so I'm a big advocate for what we're trying to do. My question is for you. With the rising chronic disease rates in Alabama and being, at the center of healthcare, how are you guys making sure patients are getting access to the preventative or self-management resources? Because oftentimes they're not. Most of my clients are actually providing the self-management programs, but they're not being referred by the physicians, and that's what we're seeing. So how are we addressing that?
So that's a really tough question. Part of the reason why I decided to take the job here is because I was told that Alabama ranks 49th in healthcare in the nation, out of the 50 states. That is a very complex question to answer, but I can tell you some of the things that we are focusing on. It is very clear that in order to address population health and to allow people to age well, to live well, that we do need to have primary care and preventive care. We do not have enough primary care physicians in the state of Alabama. We have a lot of specialists, but quite frankly, if I can avoid having a complication that requires a specialist, why not do that by visiting my primary care physician every year? So there has been a movement and a lot of funding through the federal government and the state to actually build clinics in rural communities, but also even locally, and to expand the primary care footprint. Part of that really means that we need to educate the individuals that are ultimately going to be those physicians. As I said earlier, the number of physicians relative to the growing geriatric population has plateaued. We're just not going to have enough of them. So we need to grow that workforce. And what is that going to look like in the future? Right? So we can keep on graduating the same number of medical students out of medical school who may go anywhere and stay here, but really focusing on getting those physicians that graduate here to stay here is the first part. Second is to make sure that they are pursuing primary care. So there are scholarships now that are being given out to undergraduate students that are talented and demonstrate the aptitude to get into medical school, so that they're getting full scholarships and a full ride right through medical school and into primary care. And essentially they're being asked to basically practice primary care upon their graduation. So that's one process, just creating scholarships, but it is building a workforce. The other thing is we really have to think about being a little bit more creative and thinking outside of the box, right? So the physician platform is one to provide more primary care, but could there be other platforms that we can grow across the state that can help us deliver more care? So thinking about nurse practitioners, physician's assistants that can be an extension of a group that can go out into communities and help to provide more care. That's one way to think about that. Also creating a separate type of healthcare workforce that's not necessarily a physician or a practitioner that is responsible for providing things like nutritional counseling, guidance, screening, surveillance, that allows for people to stay healthy, but also allows for the recognition of early disease before they actually need to be seen. The current state right now is that a lot of patients that are seeking an appointment are waiting months and months to be seen by a physician. And in that period that they're waiting to be seen by a provider, what do you think's happening?
They're getting worse.
They're getting worse. And not only they're getting worse, they're anxious. And so we're creating this, it's a double whammy. So these folks show up in the emergency department, and what I always get told is, well, they didn't even need to come to the emergency department, did they? I mean, really, they could have gone to urgent care, or they could have gone to their doctor. And my response is, no, actually, they did need to come in because they couldn't get to their physician. And so that's why they're here. So looking at the patient as a consumer is something that we haven't been able to do. But if we were to go back even 5 years and take a look at all the patients that showed up in the emergency department and say, well, how many of these could we have actually prevented by just making sure there was more primary care and appointments out there? I'd say it's at least 20%. So yeah, it's going to be complicated, but ultimately building that primary care workforce, giving people multiple points of access to healthcare, and decreasing that anxiety, but also preventing them from getting worse in the period of time that they're waiting. I think will all be, I mean, those will be solutions I think in the future that we really need to work on to improve the health of the folks out there.
Can I touch on one other thing that you said? You said the use of non-medical professionals. We hear a lot about community health workers. We hear a lot about community health workers, but have you guys started to utilize certified health education specialists, which are, non-medical practitioners and who can cover all the spaces that you mentioned, nutrition, we can track data points, we actually communicate directly with healthcare professionals and have access to those systems. We even talked about a model of integrating them into the emergency department to also reduce hospital admissions and readmission rates. Have you guys looked into the status of certified professionals?
There's plenty of use cases around the country that have been very, very successful. We do not have a broad use of certified healthcare professionals in our space, but we're starting to see a growth in the behavioral health space, and I'm going to tell you, it's made a huge difference. Between the years of 2019 and 2022, we saw a 60% increase in behavioral health emergencies in the state of Alabama, 60%. We did not have a workforce to address that. Since that time, we have been training certified healthcare professionals that can come in and be the buffer between the emergency health services and the psychiatrist or the psychologist that they need to see to ensure that they're not dealing with an emergent condition, but also to just basically address some of the issues that can be dealt with through counseling alone. So I've seen that used very successfully in that space, but you're absolutely right. I think that's room. And the reality is that we will not have a workforce to take care of our population in 20 years unless we're thinking about how to expand and use creative modalities like certified healthcare professionals in healthcare.
And Dr. Elie, if I could add, from my experience, what I've seen when these different agencies are using technology that is not looking at patients as a consumer, meaning they are within the platform itself, it's hard to refer a patient from coming in for a certain encounter and then refer them to other programs, right? And so it's like technology, these electronic health records were built 20, 30 years ago, and they don't have this capability. It has to be manual. You have to have folks come in and pull the data and then somehow contact patients. One of the projects we did was with the City of Kansas City and University of Missouri, where they went out to churches and were doing COVID testing. And before they got their test, they asked them multiple questions. They were able to mine that data. One of the questions were, what resources do you need? And based off of that answer, electronically, they would send them a text with those resources. So if they were asking for legal aid or homeless, they were homeless, or whatever the case was, they were able to electronically send them that information of what was available in the community. And I think that's one of the key components in technology that's missing. They may be asking the question, but how do they pull it? How do they engage? Again, there's a barrier with cost, and there's also, I think, technology is fragmented. And so now, with the new age of AI and these apps, we're going to be able to hopefully tackle those a lot better.
My name is Deborah Lawton. I'm CEO of Envision Care Management Group. So what we're doing is care management that's helping doctors with managing patients, And so I would like to know where you think care management would fit into that scenario of what is needed in the community. And also, do you have a platform that addresses care management that you set up care management for doctors' offices, a platform for that?
So thank you for the work that you're doing, and thank you for that question. You know, I remember when my mother was diagnosed with breast cancer. In fact, I diagnosed her with it at home. I called an oncologist, I called her PCP. I was trying to get in contact with a variety of folks that could see her emergently because I was worried that she had an advanced form of cancer. And I'm going to tell you, with all of my expertise, medical lingo, my ability to navigate the system, I ran into a lot of roadblocks. And this is about, I'm going to say this is not recently, but it still happens, right? And so I think to myself, you know, with all of my expertise and my agency, I can't get my mother into an appointment. I can't figure out how she can get to radiation oncology or transportation. I couldn't figure out how to do all of these things, and I struggled to imagine what it might be like for someone who did not know how to navigate the healthcare system. And so your question is perfect, because you know we have a lack of advocacy for patients in the healthcare system. We rely on them. We put the onus on them to make the call, to recognize when they're ill, to identify the resources, when in fact there's probably a better way. And so I think that the case management question is really about advocacy. How do we bring the resources to the individual so they can advocate for themselves and actually can be empowered to take care of themselves? So, not that we've done this in the emergency setting at all, but I do think that the future of medicine would be making sure that there was some arm that actually provided that level of, I want to call it advocacy, because I think case management is about really looking at the patient holistically, right? And making sure they have all the resources to set them up for success. Ultimately, I did get my mother into a great oncologist, and she got radiation oncology, and she got her one of the best surgeons. I mean, I did all the things, and she survived and she did well. But I struggled to understand what it would have been like for another person to do this on their own that was elderly, that had advanced cancer, and didn't know all the numbers to call.
For us, yes, like we handle different care management programs like Children's Special Health, CHIPS. So our platform is built to be multi-specialty. So it could be configured. The great thing about our platform is we built it so that it's referrals can come in electronically. Folks can use QR codes, URLs on your website to sign up, to even see if they qualify, right? So our platform is specifically built to allow patients to fill out any documentation that's needed, consent, and then as you review that information, you're able to determine whether they meet the criteria for that health program, or you can refer them to another one.
This has been fantastic. That was a great start. Enjoy the rest of your lunch. Enjoy the rest of your networking. If these are the types of ideas that you all have about the future, then it's very promising. And this does not have to just be here today that we've talked about it. These are things that you take back to your offices, take back to the things that you guys do. I see Amanda here from Possible Health Tech Accelerator and Matthew J. These are the kinds of ideas that you take to startups who are going to get started and say, here's some areas we've identified that we want to work on. I know that we have folks who are across the technical landscape here, across the community landscape. These are things that can be made real if we make them real, right? So, and we can do that collectively. So thank you guys very, very much for joining us today.